should have gone to the audience on mail, not now.
Let's just wait.
So, Jagdish sir, with your permission, if we can start.
Yes.
Okay.
We are live, sir.
Okay, thank you. Hello and good evening to everyone who has joined us tonight. I am Dr. Sunny Chinchan Surkar, medical advisor at Sanofi India. And on behalf of the entire CHC team, I welcome each and every one of you to the National Conclave on Insomnia Management, NCIM. The theme for today's meeting is Insomnia, the Forgotten Stories. The story of humans as diurnal beings is directed by a biological set clock, which defines our sleep and wakefulness. But like any complex storylines, an important subplot gets neglected only to hit back at the end of the movie with a twist. Is insomnia one such subplot in the story of sleep hygiene and wakefulness that has been ignored or that has been forgotten? To help us find out more on this and to enlighten us more on the subject, we have with us today our esteemed panel members. Please join me in welcoming our panel members for today. Allow me to please share my screen. So we have our moderator for today, Dr. Abhaya Jagdish sir. Just a minute, I'm sorry. Dr. Abhaya Jagdish sir as our moderator for today, Dr. Abir Mukherjee sir, Dr. Devendra Save sir, and Dr. Rajesh Nagpal sir as our speakers and expert panel members. Sir, we welcome all of you. It's a matter of great honor for us, and we are humbled and really pleased to have you as our faculty for today. Welcome to all of you, sir, once again. With this, I would like to share with you the agenda for today's meeting. Dr. Abhay Jagdish sir will be setting the context and introducing the faculty for today. And then each faculty will be deliberating for about 20 minutes, followed by a brief panel discussion along with the Q&A sessions, followed by the launch video for Still Knocked and vote of thanks. I would request all the audience to please put in your questions in the Q&A section so that we can address them during the Q&A session as well. So it's a moment of great honor for me to introduce to you our moderator for today, Dr. Abhaya Jagdish sir. Sir is director and senior consultant of the Abhaya Hospital at Bangalore. Sir has done his MD from NIMHANS in 1989. Sir has started the Department of Psychiatry at KIMS in 1993 and the PG course MD Psychiatry in 1998. In 2001, Sir has started the Abhaya Hospital, which is an exclusive neuropsychiatric center. He's also involved in organizing many academic activities like CME, seminars, workshops for PG students and also for the IPS Karnataka State Branch. Sir has been observer in the Whittington Hospital, Manchester, UK for about 3 months, and Sir has been GCP trained in 2006. His areas of interest include adult psychiatry, alcohol de-addiction, family psychiatry, and Sir is actively involved in the research activities as well. Sir, I welcome you once again. And I sincerely request you, sir, now to please take over the meeting, to please set the context and introduce our speakers for today.
Thank you. Thank you, Dr. Sunny. It's a great moment that one of the forgotten stories is about insomnia. Any fitness in India we talk about, they speak about only 3 things: diet, exercise, relaxation. And everybody wants to include only yoga. The forgotten story is about sleep. When BPOs are on the peak, when every city was buzzing with people, young adults of India working in BPO, they used to work for American time or for UK time, get back home early morning, not having adequate sleep, and they were all going through some small problems. So now, even in wellness medicine in American society, among the 6 components, diet, exercise, yoga, relaxation, not to drink, etc., sleep forms one of the major issues. Ever since electricity was invented, all of us lost 1 hour of our sleep. Today, sleep insufficiency is common in modern society and may result from variety of factors. One is work demand, especially people who are working for other country timings and in the IT industry, doctors, family responsibility, social responsibility, along with that, medical conditions and primary sleep disorders. All these are contributing for impaired sleep. A sleep debt accumulates. Individuals may experience, when they have the sleep deprivation, reduced performance, increased risk for accidents and death, and it's also detrimental to physical and psychological wellness of an individual. The psychological and physical impact of insomnia will be discussed in detail in today's discussion. That is the beauty of today. It is just not about insomnia. It is about the architecture of sleep, how the sleep deprivation insomnia can impact different aspects of our psyche and body, and then about management. All three components are extremely important. I'm sure today we have distinguished speakers who will do justice to all these three topics. Today we have sleep of two types of sleep deprivation. One dimension is duration of sleep coming down, that's quantity of sleep. Another one is depth of sleep, that is the quality of sleep. So some may have decreased sleep time, another group of people may have the quality of sleep, maybe have disturbed sleep in between, etc. The acute sleep deprivation can be 1 to 2 days, which can happen to any one of us. The chronic sleep insufficiency is when an individual routinely sleeps less than the amount required and getting exhausted. In insomnia, patient cannot sleep when an opportunity to obtain sufficient sleep is given. So that is what the difference between insufficiency of sleep and insomnia. How much sleep do we need? Sleep need varies among individuals and across the lifespan. A newborn one may sleep for 21 hours. The adult may sleep for 6 to 8 hours. So today we have two types of sleepers. One, short sleeper who can sleep for 6 hours and can be fresh for the rest of the day. Other sleepers can be long sleepers who can sleep for 8 to 10 hours and they want to be fit. But on an average, if you take 7 to 8 hours of sleep is extremely important for a wellness of an individual. With the advent of electricity, the electronic gadgets entering our bedrooms have further destroyed the sleep quality as well as quantity. So what happens to insomnia? Let us have a discussion today. The first speaker today, as I said, will be discussing about the sleep architecture and insomnia prevalence. It is not a Western story. Even in India, people have insomnia. But how they reach, most of them will reach the general practitioners or their family physicians. By understanding what are the causes, probably we will be able to manage them well. Today we have a very distinguished speaker, Dr. Abir Mukherjee from Kolkata, who is a senior consultant at Medica Super Specialty Hospital, a visiting consultant at Amri Group of Hospitals. He is actually involved in one of the greatest service to humanity, caring for the homeless mentally ill. That is Ishwar Sankalpa. Doctor, that's one of the greatest service to the society. His areas of interest are developmental disorders in children and adults, rehabilitation psychiatry and neuropsychiatry. So he has major achievements. Former treasurer of he has served in East Zone, chairman of Child Psychiatry Subspecialty Indian Psychiatric Society, IAPP. Again, he is a convener of IAPP Child and Adolescent Psychiatry Committee, and he has done postgraduate education committee, ethics committee, and IPS West Bengal around this executive committee member. He has many publications, 40 for his credit. He is also an ex-examiner in preparatory MRC Psych courses in UK, regular panelist and a regular speaker at various levels. So he has membership to Royal College of Psychiatrists and fellow of Indian Psychiatric Society. He is an extremely, his preparation and probably his depth of knowledge will help us to understand the architecture of sleep. After architecture of sleep, we will discuss about acute and chronic insomnia in special situations, including comorbidities. That is by Dr. Devendra Save. Devendra Save is one of the well-known leading psychiatrists from Mumbai. He's practicing over 2.5 decades, and he's consulting at Karuna and Bhakti Vedanta hospitals. He's director of Mumbai Psychiatric Clinic. He's director of 3Cube Medicare Services and Psychiatry Plus Technology Organization. He's also director of Vibhas Hospital, which is a psychiatry acute care and rehabilitation center. He completed his MBBS from Grant Medical College, typical Bombay 8, JJ Hospital of Mumbai, MD Psychiatry from Grant Medical College. He will be speaking about the acute and chronic insomnia. What happens when the circadian rhythm is disturbed? Here, what's its impact on individual aspects, other specialties of health, like on cardia, renal system, respiratory, etc., immunology, etc. So, welcome to Dr. Devendra Save. You will be speaking after the Dr. Abir Mukherjee. Then we have a well-known speaker who doesn't require any introduction. Still, it's my duty to speak few words about Dr. Rajesh Nagpal. Anything comes to biological aspect, people look up to Dr. Rajesh Nagpal, a senior most psychiatrist, a well-known psychiatrist, well-known academician. His postgraduate is from Jipmer, Chandigarh, a leading psychiatrist in Delhi. He was a visiting faculty at Father Muller Medical College, Bangalore, and he was a past president, chairman of National Advisory Board, Indian Association of IAPP, past president of IAPP, Biological Psychiatry, Society for Bipolar Disorders. He is also director of Behavioral and Neuroscience Academy of India. He is also a member of Central Mental Health Authority, a steering committee member of North Indian Bioethics. He is Assistant General Secretary of Indian Global Psychiatric Initiative. He is a professor of bioethics and psychiatry for Father Muller Medical College, Bangalore, Director for Education and Training in Medical Bioethics and Bioethics for UNESCO Asia Pacific Bioethics. He has many feathers in his cap. I have told you in a nutshell. Today we have wonderful speakers, and I welcome Dr. Rajesh Nagpal. You will be the speaker after Dr. Abir Mukherjee. Now it's over to Dr. Abir Mukherjee. Welcome to Dr. Abir Mukherjee from Kolkata. It's over to you, sir. Speaker on, sir. Speaker on, please. Thank you.
Good evening, everyone, and thank you for the very kind introduction. And it's really a warm evening. So, yes, and thanks for inviting all of us for this excellent meeting.
I'm sorry to interrupt, sir. We are still not able to hear you. So you need to keep the mic closer to your mouth. It's, I think.
Is it better now?
Yes, sir. This is better, sir. Thank you.
Because I was keeping the okay. I can understand now. So now it's okay, isn't it?
Yes, sir. It's better now. Thank you, sir.
Yeah. Okay. So shall I start once again? Good evening, everyone, and thanks to Dr. Jagdish for the kind introduction. And thanks, Sanofi, for organizing this excellent conclave for the evening. I think it's very pertinent and it's very important because, as Dr. Jagdish mentioned, we spend about 6 to 8 hours of our day to sleep. So it's 1/4 or 1/3 of our whole human existence. So without any discussion on this area, and leaves all discussions on lifestyle issues incomplete. And we as psychiatrists deal with sleep disorders. It's like a bread and butter to us in our everyday day-to-day practice. So without further ado, I'll share my screen. Is it visible? Hello?
Yes, sir. It's visible, sir.
And am I audible now?
Yes.
Yes, sir.
Very much. Perfectly audible.
Okay, thank you. So the broad topic for today is Insomnia, the Forgotten Stories. So I'll discuss about sleep architecture, insomnia prevalence in India, classification and diagnosis for insomnia. There might be a few overlaps here and there. It can't be helped because these are not watertight compartments that we're discussing about. It's more kind of one drawing onto the other. So the global and Indian prevalence of insomnia. So insomnia is prevalent in 10 to 15% of the general population of the world. Approximately 5.5 million office visits related to sleep disturbances were reported in the United States in 2010. It's more prevalent in women in the perimenopausal and postmenopausal transition phase, and that is to do with some kind of hormonal changes, as well as in older adults. More than 80% of adults are affected every year by the occurrence of short-term or acute insomnia. So acute insomnia is as common as 80% of the adult population. And it's about 10% in the general population in India. In India, the prevalence is more or less about 10% in the general population. So coming to the basic stages of sleep, so we classify it into two broad categories, namely the non-REM, non-rapid eye movement sleep, and the rapid eye movement sleep. So within the non-rapid eye movement sleep, stage 1 and stage 1 occupies just about the initial stages of the sleep, that is about 2 to 5% of the first cycle. Then stage 2 is about 45 to 55%. Stage 3 is around 5 to 8%. And stage 4, or the deep sleep, is about 10 to 15%. The REM sleep occupies about 1/4, that is about 1/5 to 1/4, that's 20 to 25% of the whole sleep duration. The first non-REM sleep is brief and is approximately 90 minutes. Subsequent non-REM sleeps happen about 90 to 120 minutes apart from each other. So this is how the sleep cycle goes. The sleep cycle recurs 3 to 7 times in a normal night, in a normal duration of 7 to 8 hours of sleep. But the duration of the stages varies with age. So first we have the non-REM sleep, which lasts for 70 to 100 minutes. So it begins with the shallow non-REM stage 1, which lasts 30 seconds to 5 minutes. Then there is a deeper non-REM stage 2, which lasts 5 to 25 minutes. Then more deeper non-REM stage 3 to 4, which lasts for 30 to 45 minutes. And then the REM. The first episode lasts 5 minutes. And as the night progresses, there is subsequent increases in the subsequent cycles. So stage 1 non-REM occurs at the sleep-wake transition. It is characterized by drowsiness, reduced muscle activity, and one can be easily awakened in the non-REM stage 1 sleep. The non-REM stage 2 sleep is deeper sleep than stage 1. 45 to 55% of total sleep time. We have the typical sleep spindles and K complexes on EEG. There is decreased minute ventilation, heart rate, and cardiac output. Greater stimulus needed for awakening. When we proceed to the delta, the stage 3-4, it comprises 13 to 23% of the total sleep time. It shows characteristic slow delta waves. Respiratory rate is most regular in this phase. It is called restful or restorative sleep, and highest stimulus is needed for arousal. The REM sleep, the other variety of sleep, is rapid eye movements or dreaming phase of the sleep. EEG shows mixed frequencies with alpha waves. There is something called sawtooth waves, which are distinctive of REM sleep. The skeletal muscle tone and upper airway tone is decreased, so you cannot move about normally when you have REM sleep, unless you have a REM sleep disorder, where I think the skeletal muscle tone is enhanced. There's surges in autonomic activity, which can destabilize heart rate and cause arrhythmias. So I won't repeat this. This is quite kind of a repetition of the previous slide. It describes the same thing more diagrammatically. So what are the physiological changes which happen during the various phases? So in a normal wakefulness, our heart rate is assumed to be in normal sinus rhythm. Our blood pressure, cardiac output, respiratory rate, all are assumed to be normal. The cerebral blood flow, moderate, thermoregulation, mild, gastric acid secretion, normal. So that is in a normal, healthy individual. What happens in non-REM sleep? There is bradycardia, blood pressure is decreased, cardiac output is decreased. So everything is lowered down. Respiratory rate is also decreased. Cerebral blood flow can be variable. Thermoregulation is moderate. Gastric acid secretion, again, is variable. It depends on what you ate for the dinner. So REM sleep, there will be brady, tachy, arrhythmia. in terms of the heart rate. So it can be either brady or tachy, and it can have arrhythmias. Blood pressure is variable. Cardiac output decreases further. Respiratory rate is variable. Apneas may occur. Cerebral blood flow is markedly increased. Thermoregulation is absent, and gastric acid secretion again is variable. Now, I think circadian rhythm will be discussed in details, but one of our important, topics or topical points today is about circadian rhythm, about all these, work-life balance and the changes in work schedule, the pandemic, working from home, etc. So the circadian rhythm holds a crucial regulatory role in human physiology by regulating many different body systems, including hormone production, glucose homeostasis, the central nervous system, cardiovascular maintenance, and lipid metabolism, just to name a few. And again, these systems are not in isolation, but are interrelated and dependent on each other, thus imposing the role of circadian rhythm on human physiology. Even before pathology, human physiology is determined through the circadian rhythms. It regulates body temperature, neuronal activities, hormone secretions, and the musculoskeletal systems. And it is deduced that disruption in the normal circadian rhythm can impair all these regulated systems. The regulators are directly affected by external factors such as sleep, quality, diet, and exercise. So it is not only the internal factors, it's also the external factors, the in vivo and the in vitro factors, which determines the circadian rhythm disturbances. Sleep disturbances, for example, have been linked to disorders like ADHD, neurodevelopmental disorders like ADHD. ADHD studies have shown that children with delayed melatonin secretion are predisposed to ADHD. And not only ADHD, but other neurodevelopmental disorders like autism spectrum disorders, we normally use a lot of melatonin these days with good effect. In adults, impaired clock gene expression caused by disturbed sleep have been reported to perturb the diurnal rhythms of endocrine secretion. Thus, compromised sleep has been correlated with ADHD in adults as well, as would be expected. Apart from melatonin secretion, another example of hormonal regulation is the maintenance of the hormone leptin. Leptin increases the activation of the sympathetic nervous system and increases thermogenesis by stimulating the thyroid hormones. Studies show that the peak of leptin secretion occurs during the night. Such studies have shown increased weight loss in postmenopausal women. So in a study of about 81 women in the reproductive age group, or even beyond that, between 25 to 65 years, were subjected to melatonin administration and a balanced diet to improve their sleep cycle. The tested subjects reported weight loss and improved sleep quality after 24 weeks. On top of obesity, circadian rhythms have also been implicated in other metabolic illnesses, including type 2 diabetes and several neurological disorders. Right, so this is a repetitive slide. So it also affects the bones, the skeletal and muscular functions, etc. So it does have an impact on mental health, which has been shown in two studies, a meta-analysis and sort of very recent studies by Torquati et al. In 2019, whereby it's a meta-analysis of about 7 longitudinal studies. Shift work was associated with an increased risk of adverse mental health outcomes, and specifically for depressive symptoms. Female shift workers were at higher risk for combined adverse mental health outcomes than female non-shift workers. So shift working can happen now both in person as well as online. However, this was not the case for male shift workers. So female shift workers were at higher risk for comorbid adverse mental health outcomes than female non-shift workers. So this is a very interesting observation. Adverse mental health outcome in shift work was associated with 33% higher risk of depressive symptoms. There's another study, very recent study by Scott et al., 76 publications with an N number of, 7892. Sleep and circadian rhythm disturbances were associated with a 40% increased risk of onset of bipolar disorder And we all know the relationship of sleep with bipolar disorder and the rhythm therapy, etc. So the potential sources of circadian disruption can be related to work schedules, chronotype, timing, sleep time, sleep regularity, as well as meal timings. And this in turn can result in cardiometabolic disease risks. The obesities, the diabetes, metabolic syndrome, increased blood pressure, dyslipidemia, and in general, an increased inflammation. So there are immune consequences of sleep deprivation as well. So sleep deprivation has been found to alter inflammatory immune processes via multiple pathways. Most of the current knowledge on immune effects of sleep deprivation come from studies using controlled experimental sleep deprivation protocols, among which chronic partial sleep deprivation lasting 2 to 15 days is that mostly resembling the human condition of chronic insufficient sleep. And we know the effect on health, like heart diseases. You can see that the figures indicated in red are the ones with insomnia. And this is also a cross-sectional retrospective study by Taylor et al. Of 772 men and women aged 20 to 98 years old, so across the lifespan, all adults were. So heart disease, chronic pain, breathing problems, gastrointestinal issues, high BP, urinary problems, all are on the rise when a person suffers from insomnia. So effects of improved sleep, it has a good outcome in terms of composite mental health outcomes, improving sleep on depression, improving sleep on anxiety, all statistically significant results, effect on stress and effect on rumination. So more improving sleep has a direct positive impact on depression, anxiety, and composite mental health outcomes. So the real world picture of insomnia, approximately 50% of primary care patients experience insomnia, out of which only 6% of patients with insomnia seek treatment. Only 30% of patients with insomnia mention it to their physician. This is how DSM-5 proposed sleep disorder diagnostic criteria is. So it includes insomnia disorder, hypersomnolence disorder, narcolepsy, hypocretin deficiency, obstructive sleep apnea, hypoapnea syndrome, central sleep apnea, sleep-related hypoventilation, circadian rhythm, sleep-wake disorders, disorders of arousal, nightmare disorders, rapid eye movement, sleep behavior disorder, as I was mentioning, restless leg syndrome, and substance-induced sleep disorder. So this is the proposed DSM-5 sleep disorder diagnostic criteria. Now, this is the International Classification of Sleep Disorders. So this is the ICSD-3. Prior to this, there was ICSD-2. So the major diagnostic sections include insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnias, sleep-related movement disorders, and other sleep disorders. So what is insomnia? It is a common type of sleep disorder defined by an ongoing difficulty in initiating or maintaining sleep or non-restorative sleep with subsequent daytime impairment. The sleep disturbances in insomnia is usually manifest as difficulty in falling asleep, maintaining the continuity of sleep, or waking up too early in the morning well before the desired time, irrespective of the adequate circumstances to sleep every night. That means that there's comfortable sleeping conditions, all the sleep hygiene measures has been followed. Even then, the person wakes up early in the morning. Insomnia can significantly impact daytime functioning, resulting in decreased workplace productivity. And this is the consequence of insomnia, which is very important. Proneness to errors and accidents, inability to concentrate, frequent daytime naps, and poor quality of life. So insomnia can be classified as consists of three basic types. One is acute insomnia, primary chronic insomnia, and associated insomnias. So among the acute insomnia, there is an easily identifiable causal factor, as can be expected, does not last longer than 4 months. In primary chronic insomnia, there are normally predisposing factors and precipitating and perpetuating factors as well. And associated insomnias are related to an underlying mental or mood disorder caused by inadequate sleep hygiene. And there are concomitant medical and psychiatric conditions, as well as use of substances or medications. So primary insomnias traditionally would mean that there is no other coexisting disease. It is composed of psychophysiological insomnia, paradoxical insomnia, and idiopathic insomnia. And it satisfies the 3 criteria of difficulty in initiating sleep, difficulty in maintaining sleep, and chronic non-restorative sleep for more than 3 weeks. Secondary insomnias are comorbid insomnias, which exists in conjunction with another medical or psychiatric condition. To qualify for a diagnosis of insomnia, patients must have at least one of the following complaints for at least 3 nights per week. The classical triad or the quadrant of difficulty in initiating or maintaining sleep, poor quality of sleep, trouble sleeping despite adequate opportunity and circumstances, and waking up too early. In addition, patients must have at least one of the following types of daytime impairments related to sleep difficulties: impaired attention, impaired concentration, memory impairment, concerns or worries about not having sleep. That's a psychophysiological component. The daytime sleepiness, errors or accidents at work or while driving, fatigue or malaise, gastrointestinal symptoms, lack of motivation, mood disturbances or irritability, and social or vocational dysfunction or poor school performance. So that is the ultimate consequence of all these factors. Tension, headaches, and okay. So these are the secondary consequences and daytime difficulties. So this is the insomnia algorithm for diagnosis. So if we have the triad of difficulty falling asleep, difficulty maintaining sleep, or non-restorative sleep with adequate opportunity and circumstances for sleep and the other criteria as mentioned, it can, if we can rule out the behaviorally induced insufficient sleep and the category of short sleepers, then we are left with the categories of comorbid insomnia disorders like the circadian rhythm sleep disorders, the movement disorders, the restless leg syndrome, periodic limb movement disorders, sleep-related breathing disorders, parasomnias. Then we have the medication, so substance-induced or drug-induced insomnias. Then we have the insomnias due to medical conditions. There are a plethora of medical conditions. And then we have insomnia due to mental disorders. Finally, we have the primary insomnia disorders. The categories are: one is of childhood onset with no precipitant, that is the idiopathic insomnia. Then we have something called the paradoxical insomnia, which basically means there is marked subjective objective mismatch. So basically the family members would say that no, the person is sleeping quite well, but the person concerned would say that no, I'm not sleeping at all. And extreme sleep symptoms. Then we have the behavioral, the inadequate sleep hygiene type of primary insomnia disorders. So there we have to take care of the proper sleep hygiene, mention to the individual about what are the common sleep hygiene measures. This is very commonplace in our day-to-day practice. Then we have adjustment insomnia, presence of acute environmental, physical, or social stressors. And this is chronic. In case of acute, there will be acute. And then we finally have the psychophysiological insomnias, which is a behavioral phenomenon linked to conditioned arousal, learned sleep preventing associations. So I wouldn't delve into details because I think my next speaker would be, just an outline of the various kind of common psychiatric causes of insomnia. We have the group of mood disorders, anxiety disorders, substance misuse, dementia, eating disorders, schizophrenia, psychophysiological insomnia, and life stressors, as well as the medical causes like pain, chronic pain, the cardiovascular diseases, the endocrine disorders, the rheumatic diseases, pulmonary diseases, neurological disorders, the plethora of neurological disorders, urological disorders, prostate, overactive bladder, gastrointestinal disorders, the IBS, the GORDs, peptic ulcer disease. Then we have the immunological disorders like AIDS, perimenopausal syndrome, chronic fatigue syndrome, systemic cancers, and dermatological disorders. So these are the scales which can be used. The ESS is very commonly used in cases of hypersomnia, and the ENT surgeons use it in case of obstructive sleep apnea. Then we have the fatigue severity scale, the insomnia severity index, and the sleep diary, the age-old sleep diary, where the person keeps a personal paper record of sleep and wakefulness over weeks to months, should record a detailed description of sleep, such as bedtime, duration until sleep onset, the number of awakenings, duration of awakenings, and nap times. So this is how the insomnia severity index looks like. So it's a brief screening tool for insomnia. It's available in several languages, and its psychometric properties have been well documented. The current instrument is composed of 7 items. While participant burden is relatively low when used singly as part of a longer health assessment in research or clinical practice, each item represents additional burden. Right. So I will end now and hand it over to Dr. Aravind again for the next proceedings. And then we'll have a panel discussion at the end, then I'll join again. Thank you.
Thank you, Dr. Aravind Mukherjee. Now we will move on to the next topic. What's the impact of acute and chronic insomnia, especially in special group adults, elderly, and children? So today we have another distinguished speaker, Dr. Devendra Save. Welcome to Dr. Devendra Save. It's over to you.
Thank you, sir. Thank you so much, Dr. Abir. Thank you so much for the lucid presentation, where we came to know about various aspects of sleep, its architecture. It's very clear now how important sleep is. It's very clear by the fact that God has made us sleep for at least 1/3 of our life. We are supposed to sleep at least. Now I don't know whether it has gone to 1/4 or 1/5, and what is going to happen with this hectic lifestyle. So we have insomnia as a disorder, and in metropolitan cities like Mumbai, where I practice, there are a lot of people who are having forced insomnia. I have so many of my friends, colleagues, who just sleep for 5 to 6 hours, 4 hours, because unfortunately they have to travel for 4 hours, reach their job, work. Children who are supposed to be sleeping for 9, 10 hours are sleeping for 6 hours, just because they have to finish their portion, their assignments, and also go for their coachings and whatnot. So insomnia is definitely a disorder, and I think insomnia is also getting forced on people. Now, we are trying to have a more productive life by compromising on something which is as important as sleep. Now, sleep is something which we just heard. It's a sort of a state which is not just insomnia which causes problem, but it is sleep which is essential for you to maintain a very good life, very good body, and all the organs to stay healthy. It gives opportunity for the entire body, not just your brain, to recoup and get back to a refreshed state and repair itself for next day where it is going to be used. So it's a state of hypoarousal where there is everything, all your systems are at the lowest, at where the maintenance work can be done. Now, next slide. So I will be in my presentation speaking about various effects of insomnia in various population subgroups and certain disorders. Now, why this is important is, as we just heard from Dr. Abir, that just around 6% of patients of insomnia are coming in for treatment. Just around 30% are themselves saying that I have insomnia as an issue. And we will be seeing in this presentation how insomnia affects and how it is something which we should be asking. We are just becoming aware in this small presentation which I'm making, that how it is important in various aspects and how we should be just asking patients and asking about details of insomnia, and if it is there, treating them. because it can have disastrous consequences on the outcome of the state or the illness which the person is going through. So firstly, I'll speak about insomnia in pregnant women. You'll be surprised that almost around 16 to 19% of women in third trimester and around 5 to 11% of women postpartum have insomnia as a issue, as a disorder. It's also there that what is affected because of insomnia, basically sleep disturbances are seen, sleep effort is required, sleep related impairment is there, and this leads to there is a prevalence of almost 60% at 32 weeks of pregnancy and 8% 8 weeks postpartum. Next slide. So what we can see is that poor quality of sleep was significantly associated with greater symptoms of depression and anxiety. These were statistically significant. Sleep quality is a risk factor for negative maternal affect in postpartum period, which affects not just her mood, but also the overall care of the child, of the infant. And it is very, very important that we should understand these things. And it should be sleep hygiene should be considered as a component of identifying women who are going to be at risk for a postpartum depression or anxiety. Next slide. Very importantly here, we have been saying all throughout our, I've been hearing this since I was a student, that as age progresses, your sleep goes down. The sleep reaches older people, 80s and 90s are supposed to sleep for 4 hours and 5 hours, and that is natural for them. But it's not so thought of right now. It is basically that they're suffering from insomnia, and it is going to definitely affect their health. Insomnia is associated with a risk of being underweight in elderly. It is not associated in overweight. You'll be surprised that above the age of 80, 40% of men and women were suffering from insomnia. Widowed population was also at around 40%. Rural population was comparatively better. It was around 37 to 38%, 39%. Now, living alone, again, shot it up by 5% to 45%. Those who are suffering from illnesses like lung diseases, bone-related diseases, psychiatric illnesses, and unfortunately insufficient food have it ranging between 45, 46% to around 52%. And the highest was those who are having insufficient food. A couple of slides ahead. Next slide. So basically, almost around 40+% of elderly population suffers from insomnia, and its effect on psychiatric disorders is also significant, where you can see clinical insomnia patients reported 32% of them reported anxiety, 50% reported depressive disorders, somatization was reported in 16%, and alcohol and tobacco dependence was seen in almost 2.7 to 4.9% of these people. Previous slide. So there was a time when insomnia was not supposed to be with children. They were supposed to be sleeping very naturally and nicely. But unfortunately, today, if we see, children are also affected. Studies have been done on children, and it is seen that almost a large percentage of children are having issues with insomnia. At the age, it is maximum seen in girls at the age of 11 to 12. And unfortunately, insomnia as a problem makes a predisposition for ADD, ADHD, leading to poor attention and concentration, leading to academic frustration, leading to poor school relationships. It also leads to a low motivation because unfortunately their performance goes down, and poor interest. Getting them back to a better sleep schedule leads to a lot of improvement in these issues. Next slide. Next one. So with psychiatric disorders, there is a bi-directional kind of it's a vicious circle. Insomnia increases the risk and the disorder increases insomnia. So if we take, for example, depression, insomnia increases a 6-fold risk of developing depression, and depression yields to nearly 7-fold increase in risk of developing insomnia. Next slide. So when we the significant factors which were seen, very, very significant, is that insomnia is a very high risk factor for suicidal behavior, and it is more so in individuals who are suffering from mental illness. So we should always see people who are suffering from mental illness and treat their insomnia, because it can always lead to an increase in their suicidal behavior. Also here we have a table which states a simple thing, that there are any person who is going to be suffering from insomnia has predisposing factor, including genetic factors. It's seen that insomnia is familial, neurobiological mechanisms which are there, environmental conditions, and their personality traits, like those who are more ruminative, more perfectionist, OCPD kind of people, anxious personalities, they are very predisposed to insomnia. Then comes something which precipitates it: stressful life event, some medication, drug use, or a mental health disorder which comes in, which leads to acute insomnia. And if these continue and we don't give them a proper treatment, or maladaptive behaviors continue, then it leads to chronic insomnia. So this way, a person gets from a predisposing factor to a chronic insomnia state. And nowadays, precipitating factors are ever present in our lives. Next slide. So what has been seen is that insomnia, almost 1/3 of the sample had insomnia as a disorder. I'm talking about 400 treatment-seeking outpatients in psychiatric setup, out of which 45% were suffering from major depressive disorder. Schizophrenia spectrum was 25%, 23% were bipolar, 33% were anxiety. So a large number, but this fact is known to us, large number of problems are, insomnia is seen in large number of patients of our psychiatric disorders. Next slide. Now, there is as Dr. Abir has already said, that insomnia leads to various sort of issues with your sympathetic activity. It leads to inflammatory markers being increased and dysregulation of HPA axis, which in turn increases your heart rate, blood pressure. It leads to atherogenesis, increase in levels of lipids, and insulin becomes dysregulated. You can see insulin resistance coming in. And all these things lead to a clear increase, evident increase in cardiovascular diseases. Next slide. So what we can see is that insomnia, those who had it, this was a comparative study of 22,040 people with diagnosis of insomnia versus 22,040 people without insomnia. Out of this, 68% had an increased risk of experiencing an incident MI, 85% increased risk of stroke, and 33% increased relative risk of a CVD mortality in patients who are suffering from insomnia as compared to those who are not suffering from insomnia. So it's a very, very significant thing. So if insomnia is treated and they become without insomnia, we can reduce this risk. Next slide. Insomnia is a very significant finding in hepatic diseases. Almost 60 to 80% of chronic liver disease patients report a poor sleep. 25 to 40% of cirrhotic patients report insomnia. 64% of HB virus report insomnia, and which is a very, very significant finding. There is also prevalence rate of 25% showing depressive symptoms. Anxiety prevalence was 25%, 29%, and prevalence rate of insomnia was 28%. Next slide. Renal diseases, again, there was a very high amount of insomnia. Almost 59% of renal disease patients showed insomnia. End-stage renal disease, it reached to almost 67%. And there was a very, very significant 46% of patients who were with kidney transplant also showed insomnia as a symptom. So it's very important that we ask for insomnia and treat it significantly. Next slide. In multiple sclerosis, insomnia has been seen as a very, very important factor. Almost 26% of multiple sclerosis patients showed insomnia, and they reported anxiety, fatigue, and cognitive impairment as a kind of a effect of insomnia in these patients. Next slide. Epilepsy, again, we are aware that insomnia is a very, very strong comorbidity. 65% of epileptic patients showed mild insomnia, 28.9% showed severe insomnia. And this is more significantly so in epilepsy patient, because we are all aware that sleep deprivation is a significant reason for a seizure to occur. So we have to ask for, treat, and diagnose and treat insomnia in patients of epilepsy. Next slide. In inflammatory bowel disease, almost 75% people were suffering from insomnia, and that's a very, very significant amount of number of patients. Next, to end it, almost insomnia and risk of cancer has been associated. Not many patients of insomnia are associated with cancer. For 24% overall increased risk of cancer for individuals with insomnia without versus those without risk for insomnia. The risk of developing cancer was significantly higher in studies conducted in women, but not in men. And it was in types of cancers, it was significantly higher only in thyroid cancer. But the studies would also suggest that insomnia may serve as an early warning sign for onset of cancer and provide an opportunity for early detection and early intervention. So as we can see, next slide. So as we can see, insomnia is something which is prevalent at a very, very significant rate in almost all disorders, and treating it would bring out a very, very positive outcome, not just in the treatment of insomnia, but the outcome in the treatment of disorder. So with this knowledge of how insomnia can affect various medical disorders and various subsets of population like children, pregnant women, elderly, I would hand over to Dr. Rajesh Nagpal to tell us about the treatments which are available for insomnia and how to go about with it. Thank you.
Thank you, Dr. Devendra Save.
Now it's over to Dr. Nagpal.
Thank you,
Dr.
Chairman.
Nagpal, you will be talking about molecular targets and what are the other drugs available for the management of insomnia. So today we have molecular targets as well as management options of this thing. So it's over to Dr. Rajesh Nagpal.
Thank you, sir. So thank you for your kind word, Chairman, sir. Many nuclei act upon numerous brain regions beyond their role in sleep wave regulation. So the basic point here is that the nuclei will work in various directions beyond sleep also. Hence, when we are using drugs which target these nuclei, they have effects beyond sleep also. That is the significance, clinical significance of this. The wake promoting agents and sleep promoting areas are different. The wake promoting areas start from the midbrain, have a dorsal pathway and a ventral pathway. The sleep promoting agents are primarily confined from the midbrain to the hindbrain. And that's the entire circuit here. There are two separate circuits for wake promoting and sleep promoting. It has clinical significance, which we'll come to in the next few slides. The wake promoting system, as I told you, project to various structures through the dorsal and the ventral pathway. To understand, the neurotransmitters involved in wake promotion are orexin and histamine. For sleep, you have GABA and melatonin at a very simplistic level. But the noradrenergic, serotonergic, cholinergic, dopaminergic, glutamatergic also act on the wake promoting areas. But the primary ones, as I said, for wake promotion are orexin and histamine, and for sleep is GABA as well as melatonin. So a repetition again, sleep promoting systems are GABA and galanin, which is also another kind of opioid receptor. It's an older molecule discovered. It's a peptide, and of course, melatonin. Now, there are specific distinct brain regions and neurotransmitters, as Dr. Abir pointed out. From wakefulness, you go on into the NREM stage, the stage 1, stage 2, stage 3. So a specific region in which the neurotransmitters will regulate the NREM on state of sleep. So from wakefulness, going on to stage 1, light sleep, stage 2, deep sleep, and stage 3, and then eventually, of course, the REM phases. And the cycles happen every 90 minutes, as you said. Is the galanin primarily and the GABA, which are primarily going to act to start the NREM on activity of sleep. And these are the various connections here, which are starting from the midbrain and going on to the hindbrain. The neural mechanisms for underlying the REM on state, as you know, after stage 3, you have the REM stage, which in the later half of the sleep gets more. In the first hour of sleep is, of course, less. Now, to start the REM on state of wakefulness, we have a separate circuit, again, starting from the midbrain going on to the dorsal pathway here. And then you have a specific distinct region and neurotransmitters which regulate the wake on. The person will now wake off both by the entire dorsal pathway, primarily consisting of, say, now you have the orexin and the histamine, which play a major role here for promoting from the REM of stage to a state of wakefulness in the morning. Hence, when we wake up in the morning, we are actually dreaming, because that's the last phase of sleep. And the REM phase, of course, is much more in the second half than the first half. So, as Dr. Jagdish pointed out, briefly, sleep hygiene education, of course, we are all psychiatrists, so we are aware. I won't go into all the aspects. Primarily about not trying to go to sleep, you using the bed only for sex and sleep, having a hot water bath, etc., etc. Cognitive behavior therapy for insomnia is something which all of us who are trained in CBT should try and practice and inculcate this as part of the regimen when we start treating insomnia. Now, there is nothing like today primary and secondary insomnia is just one insomnia, as we know classifications. But the various treatments which are available today are OTC sleep aids, primarily acting on the histamine neurons. They're available in the market. The melatonin drugs also available as the OTC products today. We still do not know what is the dose of melatonin. We are still working out, some going on from 3, 5, 10, 15, 20, 25, 30 anticonvulsants, relatively older molecules which would modulate the release and activity of GABA, which is the inhibitory neurotransmitter in the CNS. Atypical antipsychotics, particularly clozapine, quetiapine, the pines, act as partial agonists of dopamine receptors as well as antagonists of serotonin, noradrenaline, and choline receptors. Very crude agents to bring up sleep. Antidepressants, potent antagonists to the histamine receptors, like, for example, the doxepin, 25 milligrams, 70 milligrams, and the trazodone, used very frequently with additional effects on the alpha-adrenergic receptors and serotonin receptors. Then you have the benzodiazepine receptor agonists, the positive allostatic modulators of the GABA receptors. The benzodiazepines, very popularly right from diazepam to temazepam, potentiate the inhibitory effect of GABA, also indirectly modulate serotonin, noradrenaline, dopamine, and choline. As I said, many nuclei are involved in sleep and they also act elsewhere. So benzodiazepine is more of a sledgehammer effect. Then you have the Z drugs. They are a little more specific. They are on the GABA A receptor, of course, but they are on the benzodiazepine type 1 receptor, more towards the alpha 1 receptor subtype, and which has been implicated in sleep, but not in anxiety. And hence, these drugs do not modulate the relaxation effect, the muscle relaxation effect, or the anxiety effect of benzodiazepines, but act primarily on the sleep. They also indirectly will modulate serotonin, noradrenaline, dopamine, and ghrelin systems. And then you have the newest kid on the block, that is orexin receptor antagonist. So as I said, orexin is the wakefulness inhibitor, is the wakefulness the transmitter. And if you are going to antagonize that, then we'll start getting sleep. So that's a novel way of looking at how to work on sleep. So in brief, in clinical practice, do advocate sleep hygiene, do get a handle on CBT, you have various options available. Some of them are sledgehammer effects, like you have the antidepressant, the atypical antipsychotics, anticonvulsants. Look at today the Z drugs and the orexin receptor antagonists as the newest kids on the block to treat insomnia. So historically, the barbiturates have been in 1900s, barbitol, pentobarbital, and the host. Of course, we had breathing issues, memory deficits, motor deficit, dependency, tolerance, and of course, people committed suicide in those days with overdose of barbiturates. The benzodiazepines hailed as a very important touchstone in psychiatry, working on the GABA A receptor, a positive allosteric modulator. The problems that we are having with the benzodiazepines is memory deficits, motor deficits, dependency, tolerance, and of course, rebound insomnia. Then in 1985 came the GABA A receptor positive allosteric modulator, a very specific one working on the alpha-1, increasing the chloride flow through the GABA receptor. And they were zolpidem, zaleplon, and zopiclone. Zaleplon and zopiclone came to India and have fallen by the wayside. Zolpidem still exists. Here also we have some issues like memory deficits, some motor deficits, some dependency. We are seeing that happening in the country. Tolerance, but the rebound insomnia is generally milder in comparison to benzodiazepines. So when you start reviewing the various drugs available until the orexin inhibitors came, we find that compared to over-the-counter preparations, the benzodiazepine receptor agonists, benzodiazepines, the strength of recommendation is still very weak, and the quality of evidence also is low. So that means that a lot of work is still required to be done in this area. But a long history of use of of the Z drugs, particularly for sleep, has been there, and there's a lot of confidence among the Indian psychiatrists, at least, for the use of these molecules. Now, if I go back to the previous slide here, we find that melatonin has got a weak recommendation. But we are now discovering very interesting, as I said, these neurotransmitters basically act on not just melatonin receptors, but have effects on all the receptors. So today we are finding interesting effects on reverse aging with using melatonin. We are also finding, obviously, that the cardiovascular diseases, neurodegenerative diseases like Alzheimer's, Parkinson's, Huntington's, amyotrophic lateral sclerosis, and of course, cardiovascular diseases. If you are going to work at anti-aging, look at cardiovascular and look at degenerative. So melatonin has a positive effect on reversing aging in cardiovascular and neurodegeneration. It's become one of the other drugs also to be pursued for aging today. It has got effect on the gallbladder, vascular system, colon, lung, neural systems, kidney, bone, liver, adipose tissue, skin, meaning thereby that these drugs are waiting to be rediscovered, and applications are immense today based on current knowledge, unlike what we understood in the past. So basically, it's trying to abort the cell death which occurs with brain injury, with liver damage, or with bone health. Melatonin has their effects at the regulatory level as protective levels. The idea is that melatonin, orexin inhibitors, or the GABA A positive allosteric modulators all have effects beyond just sleep. So chronobiology improves and actually reverse aging occurs. Now, if you now shifting focus, benzodiazepines, as we know, are long-acting drugs that bind to GABA receptors, alpha 1, 2, 3, and 5 subtypes. They are less effective in reducing sleep latency, that is the amount of time you require to fall asleep once the moment you hit the bed. Benzodiazepines have been known to cause more cognitive impairment, and benzodiazepine potentiates CNS depression, suicidal behavior, and impairment with other sedatives and alcohol, a common problem faced in India today. The hypnotics, on the other hand, the Z drugs, are shorter-acting drugs that bind selectively to the alpha-1 hypnotic subunit and exhibit a unique receptor interaction by increasing the chloride channel flow, and the effect of GABA gets potentiated. It is more effective at reducing sleep latency, which is the amount of time that you take to fall asleep. Do not cause as much cognitive impairment as benzodiazepines, and CNS depression also not likely with Z drugs unless they are taken with alcohol, and of course, suicidal behavior does not increase with Z drugs. But so the same thing, benzodiazepines are a sledgehammer effect, large receptor occupations, obviously effects on anxiety, effects on the muscle relaxation, short and intermediate acting, and 10 to 40 times greater myorelaxing effect compared to hypnotics. Hypnotics, specific for sleep, fewer awakenings, greater ease of sleep onset, improved sleep time, fewer rebound insomnias, less psychomotor impairment, and much less residual impairment, improving daytime functioning, meaning that hypnotics are a more precision medicine, benzodiazepines are a more sledgehammer effect on sleep, besides on anxiety, besides on muscle relaxation. So, one common question that we are asked that why do you not prescribe benzodiazepines for insomnia per se? Number one, they induce sedation, which is beyond the sleep time. So you'll have, daytime somnolence. Chronic use may increase the risk of falls and confusion in the elderly, very common sundowning effect, inducing daytime sleepiness, associated with decline in daytime performance, driving test performance, and increase the potential for involvement in motor vehicle accidents. In fact, the newer drugs like the orexin inhibitors are today tested for sway effect, both at midnight and in the early morning. And also they are subjected to a driving test today, where the person is made to drive a car for about 100 kilometers and seeing the amount of sway that is occurring on the roads. The sedatives like benzodiazepines are associated with cognitive impairment, increased mortality, and potential for dependence and abuse, and a possible risk for developing dementia, just like the anticholinergic drugs, which are currently under the microscope for possibly increasing degeneration. Now, when you compare the lemborexins or suvorexin or daridorexin, that is orexin inhibitors, and you compare the Z drugs and you compare the benzodiazepines, we find that the effects of Z drugs and the orexin inhibitors is quite similar, except that the action is on the GABA, as I said. For the lemborexin, it's a dual orexin the receptor antagonist working on the orexin 1 and 2 receptors. More importantly, the cognition effects might be slightly lower with the lemborexin compared to the other drugs, but the risk of tolerance is also mild with the benzodiazepines, and there is no risk of dependence with lemborexin. So possibly you have, but the important aspect is that we do not have much information as of today with lemborexin available in the country, that daridorexin and suvorexin are not available in the country. Well, the Z drugs, we have lots of experience today, and we are fairly confident about the use. Now, if you compare the newer drugs for insomnia with the orexin inhibitors, we find that all the aspects are, one, it has a rapid initial absorption for fast onset action. We found the effect of Z drugs on sleep latency is very good, which is important because that's how you get satisfaction on sleep. Extended plasma concentrations beyond 3 hours compared to, so zolpidem is available in the country in SR preparation, in which beyond 3 hours you extend the plasma concentrations so that the mid insomnia will not occur, and you'll have improved sleep maintenance during the night. So so after 7 to 8 hours, the drug is completely eliminated, meaning thereby it will have no daytime somnolent effects, and the next day the person will be bright and fresh. So if you compare today zolpidem with other drugs, with benzodiazepines, similar efficacy, but does not lead to tolerance, withdrawal phenomena, or REM rebound. With melatonin, as I said, it's a dangerous drug to use if used and at the wrong doses. Sometimes high doses can cause delirium, and so that's why we need to be extremely careful. And zolpidem is a more precise medication for sleep than melatonin. Zolpidem versus DORAs. We do not have long-term safety data for DORAs except for 1 year. And the Sunrise 2 study was for 1 year, and the Sunrise 1 study was for only 21 days. And you also have, of course, somnolence and drowsiness and sleep paralysis in some patients as a known side effect of the orexin inhibitors, also called as DORAs or dual orexin receptor antagonists. Now, zolpidem, as I said, works on the benzodiazepine 1 receptor. It will work on the alpha 1, and it will increase the GABA chloride channels, and the effect and the inhibitory effect of the GABA will take place and sleep will occur. Higher affinity for the alpha 1 and the alpha 5 subunits in comparison to benzodiazepines, which acts on the entire GABA receptors. As I said, at the cost of repetition, the pharmacokinetics is that sleep latency is less with this. There's a rapid sleep onset, as I said, with the Z drugs. More importantly, after the first 3 hours, when the person is like to wake up because of insomnia, the 12.5 milligram dose of the zolpidem in the SR preparation is superior to the plain because it gives you a sustained delivery for sleep maintenance. And then both of them come back to the same level here, meaning that after the sleep is over, the person will wake up fresh with no residual effects. So rapid initial absorption, so sleep latency is less. And then, of course, we already said that, and the person will wake up fresh. Now, zolpidem extended release, with its biphasic release profile after 3 hours, improves the pharmacokinetic and pharmacodynamic profile of immediate release original zolpidem. Has a similar half-life, rapid onset of action, similar minimal residual effects, and similar safety profile. The attainment of therapeutic plasma levels and onset of action are rapid with zolpidem extended release, maintaining higher plasma level beyond 3 hours post-dose. So there is sustained efficacy through the middle of night, low risk of impaired performance the next day, providing a faster return to sleep following nighttime awakenings, making this a very useful drug in armamentarium for sleep. A little briefly about orexin. So hypocretin or orexin situated around the hypothalamus area, fairly restricted, coming from pro-orexin, orexin A and the orexin B. The orexin A peptide acts on orexin 1 and the orexin 2R. The orexin B only acts on the orexin 2R. The important thing to remember is that the orexin 1R promotes wakefulness via regulation of neurons involved in the REM sleep, while the orexin 2 promotes it both REM as well as non-REM sleep. So the non-REM component of sleep, it is the orexin 2, and the REM component is the orexin 1 receptor. And the activation of orexin 1R and orexin 2R is responsible for the transition from a sleeping state to a wakeful state. So orexins regulate wakefulness through targeted signaling downstream in the wake promoting regions. We saw that if you are able to inhibit the orexin here, the sleep area will become extremely active. The orexin 1R will act via regulation of neurons involved in the REM sleep, while the orexin 2R will involve both in the REM sleep as well as in the non-REM sleep. So that is the 1R which is working on the REM phase, and the 2R working on both REM as well as non-REM phase. It's a repetition of the same thing. Now, there is also clear correlation between insomnia and orexin levels. So if a person has got insomnia, orexin levels are very high, meaning thereby, if you're going to use an inhibitor, you're going to get good sleep. And of course, there is now correlation available in the animal studies and in the human studies also of plasma level increase in the depression and bipolar disorder in patients having insomnia in both depression as well as and more with bipolar and less with major depressive disorders. So we know how lemborexant will work. What lemborexant does is that it basically binds on the receptors. It'll bind on the orexin producing neurons. It will stop the wakefulness, and the person will go to sleep. That's a cartoon here. In insomnia, you have a high orexin tone. You have the sleep center regulated by the GABA, as I said, and by the melatonin. The wake center regulated by the orexin as well as the histamine is very high, and the sleep center is very depressed, and the person is having insomnia. When you're using an inhibitor, which is working on the orexin tone, reducing the tone here, the wake center gets suppressed. The orexin gets suppressed, and the sleep center governed by GABA as well as melatonin gets activated, and person gets into sleep. So the novel mechanism is it doesn't activate sleep center, but it deactivates awake centers. The GABA on which benzodiazepines and the Z drugs act has a wide distribution throughout the brain. Effects are on sedation, anti-anxiety, and muscle relaxation. Mechanism is enhancement of GABA receptor activation, not only active on GABA sleep, but also on the other GABA pathways. As you know, GABA is a very important inhibitor of the brain pathways. So it works there. Orexin is a little more specific around the midbrain hypothalamus area down to the hindbrain here to the brainstem area. Local distribution works on wake state initiation, wake state stabilizing. Action is on the antagonism of orexin receptors, and only the relevant pathways of wake get targeted. Since lemborexant is available in the country, we need to point out that narcolepsy is an absolute contraindication for using lemborexant. Drug interaction with antifungal agents and famotidine is known, and the doses might be between 5 to 10 milligrams, start with 5 and go on to 10. But somnolence and drowsiness is a known side effect and a part of the ADR with lemborexant. There has been a meta-analysis today which is comparing daridorexant, suvorexant, as well as the lemborexant, suggesting that it has got a good effect in both objective measures as well as subjective measures of sleep, that is with the polysomnography as well as with the sleep diary. Now, if I might summarize, I'll say this much, that zolpidem is a drug which we're using for a fairly long time now. We have ample experience with it, using it for all kinds of insomnias. Lemborexant is a new kid on the block. We are still to get studies done in India. We are working on a phase 4 year. It's approved here, but it's early days yet to see the utility. Suvorexant and daridorexant have yet to hit Indian shores. With that, I thank you very much.
Thank you, Dr. Rajesh Nagpal. So now coming to the issue now, so many drugs are in our armamentarium. For example, I just want to start with a small discussion. Recently, one of our doctor's daughter was having insomnia, secondary to many other problems in the US. Do you know the doctors, what they did? She also had a seizure. And for which, with the sleep deprivation, the treatment they gave was gabapentin, and they gave her promethazine. You just take Benadryl. When the patient did not improve, the next day they gave was trazonil. Still the patient did not respond. Then they wanted to review. This is how they did not follow any standard protocol. So today we are coming to the discussion that similar such situation we may also encounter in our practice. I have a small question to Dr. Rajesh. Sure. You spoke about melatonin. You spoke about Z drug zolpidem. Unfortunately, we are using either melatonin start from 3, 5, 10, what you said, or zolpidem 5 mg, 10 mg, and sustained release 12.5. Fine. But there are some companies who have come out with combination of zolpidem with melatonin. What's your take on it?
Sir, fixed drug combinations in psychiatry, with the exception of olanzapine fluoxetine combination, to my mind, should not be used. For a variety of reasons.
Absolutely, I agree. But what are the disadvantages?
Sir, number one, I said, and I'm saying it again, I said, we do not know what is the dose of melatonin. We are still
Absolutely.
troubled by this dose. So it is not wise to use a drug once you do not know the dose. Always wise to use it separately. My submission is that we began using with 3 milligram melatonin about say 2 or 3 years ago. Today we are going on to 10, 20, 30, and we are getting a better response. So it's early days yet to find out a dose. And now we need to do blood levels and see what is actually happening, and do some sleep studies also. So my suggestion is no, there should be no kind of fixed drug FDC for any sleeping drugs.
So what you are trying to tell me is these cocktails are not the one which should be chosen by doctors. Am I
Yes.
right?
Yes, sir.
Coming to Dr. Devendra Save, you spoke very well about sleep problems in elderly children. In children, what can be the first line of drug, and what are the drugs, if required, can be used?
So the first line of
Because
drug which
pediatricians are
which can be safely recommended and is vastly recommended is again melatonin.
yes.
It has been safely used in children. It has been quite well used in children. Melatonin works very well. Another thing which should be done is in all insomnias, I would say, we should definitely first look for the non-pharmacological interventions, which is becoming, in fact, CBTI for insomnia has become one of the first line treatment for insomnias. So we need to see for children, especially behavioral interventions, looking at their sleep hygiene, the way their lifestyle has become, the time of waking up, maintaining the lifestyle, waking up time, the use and restriction of gadgets beyond a particular time, use of nowadays, a lot of children are asking their parents to, or they're getting themselves also something like a Red Bull, and they take it in the evening time. And these are factors which can lead to insomnia or other things. But melatonin works pretty well.
Because pediatricians are tempted to give one OTC drug called promethazine. They just tell, okay, you give 1 teaspoon at night, the child will. Or some of them may use, if the child doesn't respond, they go for Benadryl. What's your take on it?
Benadryl has been a very, very
these are the two popular
drug.
drugs written by pediatricians. These are the two popular drugs written by pediatricians. If you see the prescription for insomnia.
Right. But now I think melatonin is creeping into their prescription.
Dr. Abir Mukherjee, sir, elderly also, you spoke about circadian rhythm, etc. A lot of elderly people come back. In Indian context, there are many factors which contribute for disturbed sleep in elderly. Uncontrolled diabetes, BPH, bronchial asthma, or like weather like Delhi, which can be leading to chronic bronchitis, etc. What can be the drug we can suggest to them? Because most of the bronchodilators are also come in the way of sleep.
I think the drug which is getting more and more popular in extremes of age again is melatonin, because of its safety profile and everything else. It's just that, as Dr. Rajesh Nagpal said, that we are still in early days in terms of the dose of melatonin, in terms of whether it is immediate release or sustained release. There is a lot of studies going on with regards to sustained release melatonin as well. So once we have more knowledge about melatonin, again, melatonin will be a very, very useful addition. Also in terms of BPSD, also in terms of the sleep-wake cycle disturbances in dementia. There also melatonin would be extremely useful. It's only, again, as Dr. Nagpal mentioned, we have to be careful about the doses. We don't just hype up the dose indiscriminately, which can lead to delirium and all the other consequences. Again, melatonin can be used safely in ICU setting for delirium.
Right, for delirium.
Yeah, for delirium. But again, if it is a two-edged sword. So if we increase the dose to something beyond the normal, then there might be some kind of problems with regards to that. The other thing about children, because I work a lot with children, there is also a propensity to use cyproheptadine in children for sleep induction.
Yeah,
sleep induction as well as
cyproheptadine.
As well as appetite stimulation. So that also, I think, is not a very good practice. So that is also what we need to seriously, because it's, apart from anything else, it's also a serotonin agonist. So it can cause, I mean, if it is,
in fact, depression.
Yeah, if it is combined with an SSRI in depression, it can cause serotonin syndrome and all those kind of things. So That is another molecule which is used very commonly and which should be denounced.
Okay. Thank you. For short-term insomnia, would you like to consider any Z category drug in elderly?
Yes,
Because
Z category drugs.
given in
Z
mental
category
condition.
drugs are quite okay in the elderly. So it would be short-acting zolpidem or even long-acting zolpidem, because if there is non-restorative sleep or wakefulness after sleep onset, but I would rather start with an immediate release and then move on to more something like a long-acting, just to see how the individual can cope. Because all the wrong things, all the bad things about the non-specificity of benzodiazepines are not there with drugs like zolpidem, because it's a non-benzodiazepine. It doesn't have all those other potentially deleterious side effects which are known with benzodiazepines. So yes, Z drugs can definitely be used. With regards to lemborexant and adult, and old age, I'm not too sure. It's still with. I won't be able to answer that, because it is. Dr. Nagpal might be able to answer with regards to the use of the orexin antagonists in old age, the DORAs in old age. I'm not too sure about it.
Yeah, maybe I'll just interrupt. See, basically, DORA's Sunrise 1 study had only elderly population. So 65 years and older males, 55 years and older females. There was no young population in the Sunrise 1 study. Very carefully designed study to see the effect of the DORA on the elderly population, came out tops. 5 milligram is the dose for elderly, not 10 mg. There is clear data for that. After 10, there'll be a problem. Number one. Number two, even with Z drugs, there is clear level 1 studies for zolpidem for dementia in sleep. Level 1 studies are available now. So both for zolpidem as well as, but of course 6.25, and for lemborexant, for both of them are approved today for the elderly population based on the evidence-based medicine only, not on my own experience, based evidence-based.
Thank you. Tell me, Dr. Save.
Ramelteon is also another drug which can be used in elderly. It's
Which one?
Ramelteon.
Okay.
Which can be used in elderly.
See, regarding what Dr. Rajesh said.
Ramelteon is just what Dr. Nagpal had said. It is a melatonergic drug, M1, M2 it works on. And it's shown minimum amount of adverse effects in elderly. And it is quite safe with regards to adverse effect profile also.
I think the problem with Ramelteon is the availability nowadays. It is.
Yeah, I know. That is the only
quite
thing.
like those
But otherwise, it was quite safe and very good. Ramelteon had a.
It is quite like the acinapine. It was working very well. Suddenly it was taken away
I know. I still remember that drug.
Now, as Dr. Rajesh said, in elderly individuals, though in chronic insomnia, Sunrise study says one can use that lemborexant, but what we have seen, one should restrict to 5 milligrams only, because the sedation, 8 hours of sleep, lot of patients have come back and said, Doctor, this morning when I wake up, I still, because these elderly people are not used to sleep for 8 hours. And when they get up for other conditions like passing urine, etc., all, they feel giddy. One should be extremely careful. What I want to ask Dr. Rajesh is, they say in the Sunrise study and all those things, chronic insomnia, the drug of choice is DORA, 5 milligrams.
Yes and no. Number one, both Sunrise 1 and Sunrise 2, the sample is very small. So it's still early days to see, number one. Suvorexant is an older molecule than lemborexant, or in country. With that, yes, the data is still showing some interesting results. But it is not the only one. There are other drugs also which are equally good to my mind. My submission is that when you are starting to use drugs like lemborexant in the Indian population, try and use them in treatment-naive patients. Don't use them in people who have already given them a dose of doxepin or a dose of trazodone or a dose of Z drug or some other means. Use them in treatment-naive patients, get experience, and then go on to use it in those difficult problems. It's not a panacea, not like the clozapine in schizophrenia. Specific drug, specific population. Sorry. Yeah.
One more thing I want to tell is, if that is combined with other psychotropic drugs, disastrous. The drowsiness and other things are extremely. When it comes to now, the Z drug, okay, Dr. Devendra Save, your experience between using a plain one and a sustained release. Because when earlier for some time, we had that sustained release launched in India a couple of years back because of the cost, etc., that was withdrawn. Now again, it's planning to get back to our Indian market again. Do you have any experience of using plain zolpidem versus sustained release? 3 milligrams for the first half, 6.25.
So the choice is very clear. Wherever there's a problem with sleep initiation, a plain IR works pretty well. If a person has a problem with the other aspects of insomnia, the middle and late aspects, then the extended release is something which is very essential. Now, Stilnoct, as I had been using it very, very strongly. In fact, Stilnoct is one drug which works both in the initiation as well as maintenance of sleep, because its formulation releases a large amount of it during in the initial first IR kind of a phase, and then a sustained release of the further remaining 8 milligrams or so, 7 or 8 milligrams takes place over the ER formulation. And it manages to sustain the levels of the drug in the body. Because unfortunately, sustained release or not sustained release, it is not going to affect the half-life of the drug. It's going to, this manages to sustain the level of the drug in the body. So it gives you a sustained effect over 8 hours or so. In a case, extended release like a Stilnoct can be used in both only sleep initiation disorder as well as a complete sleep insomnia disorder.
May I add a point on this, please?
Yes, surely.
Yes, Dr. Abir.
Yeah, I think, whatever the literature says, first is I completely agree with what Dr. Devendra has mentioned. And I'll just add on that, it's like, again, using methylphenidate. So maybe in an old age individual, I might begin with an immediate release and then switch on to just to see the tolerability and then move on to the sustained release. But more importantly, even in young ages and in adults, even though literature doesn't mention about any addictive potential, but it mentions about tolerance. It doesn't mention about dependence, but it does mention about tolerance, and tolerance is high with immediate release. So there has been reports about, people consuming 40, 50 tablets of Zolpidem. So that is another risk, and it seriously induces seizure disorders on withdrawal and things like that. So there also, I think the sustained release would have something like Stilnoct would have a distinct advantage, because I don't think that I've heard about any kind of overdose or increased, I'm not overdose, but increased tolerance to the effect of Zolpidem sustained release vis-a-vis immediate release.
Some of the patients, when they go to alternate therapy, I have seen the prescriptions of this, especially Ayurvedic doctors. Homeopathy, nobody writes what's the content. At least what we have seen, anybody, if you have any idea about, some people keep on prescribing ashwagandha. You take that ashwagandha with milk and ghee at night, you will have good sleep. See, though we don't have that knowledge, but we have no reason to criticize unless we know. If anyone knows anything about it, can tell. Some of those, what we call it, herbal preparation. One of the commonest herbal preparation prescribed by Ayurvedic doctors in India is ashwagandha.
Can I say something, Dr. Nagpal, please? Then I'll say.
Please carry on.
A couple of things. I have seen people taking ashwagandha in the morning also to give them energy throughout the day. So
that's also there, but also sleep.
And what my Ayurvedic friends have told me is that Jatamansi Ganavati is something which helps Brahmi, Vacha. These are more so of sedative kind of things. If associated with a manic or our age-old Serpentina, Sarpagandha, definitely is something which Ayurved people use for inducing sleep, definitely with its adverse effects. Jatamansi, I've seen working pretty well as a co-prescription from some of my Ayurvedic friends.
Dr. Rajesh?
I'll just add here one thing to this, to the discussion. There is today in the market at least 4 brands of cocoa or chocolate powder or cocoa with melatonin. And the dose, interestingly, of the chocolate advice, so you have this 1 tablespoon to be put in milk and taken at night, like a hot chocolate, is 5 milligram of melatonin. So 5 milligram melatonin with a spoon of chocolate in the chocolate is part of an OTC preparation available in all stores today, at least in Delhi, very easily available today. And very popular brands are now being marketed, especially same melatonin with cocoa.
Okay.
So
Now,
meaning thereby that
before
it's a
we
very big problem which is being handled by the industry in a very difficult fashion.
Absolutely right, because they are all mostly not very well regulated, just like how we are reading Burnetta is full of sugar. Fine. Now coming back to the same system, I have one more question before we wind up, because we are on time. We have two Z drugs available in India, Zopiclone and Zolpidem. What's the choice? Dr. Devendra Save, your experience, quick, because we will go around before we conclude.
Zolpidem sustained release, I have always used
No,
it very well.
Zolpidem versus Zopiclone.
Zopiclone, the disadvantage, it's a beautiful drug. Disadvantage is that bitter taste in the morning, which patients
Zopiclone doesn't have much. Zopiclone doesn't have much. A lot of people who come from US, they will be keep on asking, give me Zopiclone.
No, I have a lady who's come from Europe and she's taking it and she's very happy. No, I don't have further experience on it.
Thank you. Rajesh?
Very limited. Only Zolpidem.
Abir sir?
Only Zolpidem.
Abir sir?
I have used plenty of Zopiclone, not the Zopiclone, in UK when I was working in UK for 8 years.
Yes.
Because Zolpidem was hardly available over there. As Dr. Devendra mentioned, it has a lot of bitter taste. Zopiclone doesn't. And at least theoretically, Zopiclone has some action on comorbid depression. But to be very honest, I'm not sure whether the Zopiclone available in Indian markets are that popular. So I didn't get the chance to use it. But I've read it in literature that it can be used with comorbid depression and add-on depression. So instead of using something like a mirtazapine or perhaps a trazodone, I'm really not sure whether Zopiclone can be used. But again, this is theoretical knowledge. It's not backed up with practical experience.
Thank you. Before we wind up, one last question to everyone. Start with Dr. Abir only. Doctor, where do you position this Z molecule? Zopiclone or Zopiclone or Zolpidem? Where do you position this molecule in the armamentarium?
I can only say that, I have used a lot of Stilnox when it was available. And when it went off market, I was pretty insecure about what will happen to the patients, as with many other, as I mentioned about acinapine. And there are so many other molecules which suddenly goes off the market, straight off the tangent. And so, and at that stage when Stilnox went off the market, the others were also not that readily available. So I had a lot of my patients on a prescription of long-acting Zolpidem. So within the Z drugs, definitely one of my first choices would be a long-acting Zolpidem. That is because of
Dr. Devendra Save?
Experience in use.
The same here. The past experience with Stilnox has been very nice, especially Stilnox as a brand for a long-acting extended release has been definitely very much better. I'm not here to just because you asked this question. I'm not advocating, but it has been
positioning.
Positioning definitely. See, if a patient comes with comorbid depression, I would rather use a tricyclic or a mirtazapine or a trazodone. If he comes with anxiety, I would position a benzodiazepine, which is comparatively like a clonazepam or a diazepam as compared to others. If it comes to insomnia, where I have to treat insomnia, I would definitely position a Z drug, Zolpidem. And if it is a complete insomnia, then a long-acting would be something which I would happily use.
Thank you. Dr. Rajesh, last word from you.
So treating insomnia based on the evidence-based medicine and the years of experience that we have had in India with Zolpidem, I think that is the first drug of choice today. The others are coming in, but right now, this occupies a number one position as far as management of insomnia is concerned.
Before I conclude, I also would like to tell, in many medical comorbid conditions, especially if a patient, elderly man, having along with bronchitis or chronic asthma, etc., having these problems, I have used this, especially cardiac patients also, a small dose, 5 mg or 6.25 has definitely benefited, especially in many medical conditions where we don't want that respiratory distress to happen and not to have. I think we have used it safely with a small dose. I guess today, as of today, this Z molecule has some life in the market in spite of so many other drugs are coming into market. Lemborexant, I am using it, but mainly 10 mg, lot of patients are finding it difficult to tolerate. Morning drowsiness. And if they have to go to work driving by themselves, because nobody will have 8 to 9 hours of sleep. So that's the one area which is coming in the way. A lot of software people, they say, doctor, I feel too drowsy. Thank you very much. It's a good drug on Saturday, Sunday, but not on other days. So keeping all these things on mind, probably today we have this zolpidem, especially if it comes to the market again with the sustained release, using a small dose will be very beneficial in many medical comorbid conditions. With this, I thank all the. Yes, Dr. Yes, Dr. Yes, Dr.
So I think it is, you're absolutely right, and it is quite, because histamine and orexin are wakefulness promoting agents. So the same happens with the antihistaminics as well, isn't it? Like the ones in the mirtazapines and everything. So those causes early morning drowsiness. The quetiapines, the pine drugs.
True.
So it would be expected. The same thing would be expected with lemborexant as well. So maybe there's some kind of dose adjustment needs to be in place at some stage.
But to be very honest, we should be thankful to Sanofi for one reason: choosing the best speakers with the best way of presenting precisely to the point. I think if somebody has gone through this today's thing, they have learned everything about sleep management, irrespective of circadian rhythm or at a different age group, what happens, and the medication. So thanks to all the speakers, and it's over to Dr. Sunny.
So thank you so much. I think it was a really informative and illuminating session, I must say. So thanks to every one of you for giving us this such a wonderful session. With your permission, sir, I would now request Brahmesh to play the launch video for Still Knocked for a few seconds, if you'll allow. So with your permission, Brahmesh, can you please play on the launch video, please?
Yeah, sorry, just a
Does insomnia rule over your patients' nights and affect their mental and physical health? The reported prevalence of insomnia is 9% in the general population, and about 30% of people suffer with occasional insomnia. For helping millions of patients with insomnia, introducing Still Knocked, offering good nights and active mornings to your patients with insomnia. Still Knocked contains zolpidem that binds selectively to the alpha-1 receptor subtype of the GABA-A receptor. Still Knocked comes in a bilayered prolonged release tablet. The first layer of the tablet is 60% immediate release, which helps to initiate sleep. The second layer is 40% extended release, which maintains sleep by reducing the number of awakenings. Prolonged release tablet helps maintaining the sleep for 7 to 8 hours compared to zolpidem immediate release. Zolpidem prolonged release provides greater plasma concentration beyond 3 hours compared to zolpidem immediate release, therefore reducing the number of nocturnal awakenings. In addition, zolpidem prolonged release tablet preserves the sleep architecture at the beginning and after 2 weeks of treatment. Zolpidem is a more suitable option than benzodiazepines for insomnia because of its minimal effect on psychomotor and cognitive performance and lesser rebound insomnia. In comparison to benzodiazepines, the likelihood of abuse occurring with zolpidem is much lower. Ensure good nights and active mornings for your insomnia patients with Still Knocked 6.25 mg and Still Knocked 12.5 mg prolonged release tablets.
Thank you, Brahmesh, for the video. With this, with your permission, I would like to give the vote of thanks as well. My first sincere thanks would go to all the participants today. for having shown interest in the meeting, for sparing your valuable time, and also for your active participation in the meeting. I would request all of you to please fill in the feedback forms which will be sent to you. It helps us understand your opinion and suggestions so that we can include the same in our next meetings to make your experience better for such meetings. I would like to thank the entire CHC team who have been working tirelessly to make this meeting possible. So thanks to every one of them who have been working tirelessly for making this meeting possible today. And I would also like to thank the HiDoc team for providing us the platform and collaterals for the meeting, the Scientimet team for providing us the content for the meeting, which was shared to the speakers. And also, I would like to thank, of course, our faculty, our panel members today, Dr. Devendra Savis sir, Dr. Apir Mukherjee sir, Dr. Rajesh Nagpal sir, and Dr. Jagdish sir. Thank you so much. It wouldn't have been possible without your guidance, your invaluable time and support. A special thanks to Jagdish sir as well for guiding us throughout the event, for giving us suggestions and helping us out with certain aspects of the meetings as well. And sir, thank you so much for being with us for the every step of the meeting. It was because of you that this meeting became a reality today. So thank you so much for helping us out on that, sir. Once again, thanks to all of you. We hope this story will not be forgotten, and we wish you a lifetime of good nights and active mornings. And on that note, this is Dr. Sunny Chinchansurkar signing off for today. Thank you very much, everyone. Have a nice day. Thank you.
Thank
Good
you.
night.
Thank you.
Thank you.
Bye bye.